Thank you for tuning in to the Louisiana HIMSS podcast, where we have engaging conversations with Louisiana healthcare leaders. This podcast is a production of the Louisiana chapter of HIMSS, the Healthcare Information Management Systems Society. Please welcome our host, President of Louisiana HIMSS, Sidney Bennett.
And we are back on the Louisiana HIMSS podcast. I am your host, Sidney Bennett. Today, here we have Ryan Cross from FMOL. Welcome, Ryan.
Thanks for having me on.
Absolutely. So we'll get right into things. So you are, title recently changed. You're now the Chief Government Relations Officer at FMOL Health System based in Baton Rouge. So tell us, what does that mean? What do you do for the system?
It's a great question. One I often try and explain to my wife and friends. I am the head of public policy and lobbying for the health system. So whether you're talking about the State House here in Louisiana or in Jackson, Mississippi, or up in Washington with our federal government, I work with lawmakers and appointed and elected officials on matters of health policy or really any kind of public policy that could impact our team members, the patients, and the communities that we're privileged to serve.
And so do you employ lobbyists under you, or do you consider yourself a lobbyist?
So I'm a lobbyist here in Louisiana, and I have an incredible team of public policy experts that work with me, lobbyists that are up on the Hill, that are based in Washington, some that are based in Mississippi, and then obviously a team here in Louisiana. And we're all focused on achieving those public policy goals for the organization and advancing things that are going to improve the health and lives of the communities where we serve.
That's awesome. And how does that work with other health systems? Do you team up with other health systems in Louisiana to kind of lobby together, or?
You know, today, I know we're going to be talking a lot about the big, beautiful bill, and it's a perfect example of an opportunity where we worked with health systems from across Louisiana and really across the country. We were working with University of Kentucky. We were working with some health systems out of Florida and Texas, all with common goals focused on how we can protect the vital funding for the communities that we take care of and for the hospitals.
Awesome. Yes. So the focus for today's conversation will be largely around the one big, beautiful bill that just recently passed. I feel like every day there's been something new with it until it passed here recently. So ton of talking points in this bill. I mean, healthcare wise, non-healthcare wise. Tell us, what is the bill and what are some of the key components as it relates specifically to healthcare?
Well, I think the big piece that is not arguable is that the bill is big. I think depending on where you sit, you might have different opinions on how beautiful it is. And it does everything from extend President Trump's tax cuts from 2017 to removes taxes on tips and overtime, to potentially gutting the Medicaid program just a few years down the line. And so, you know, when you look back specifically across the healthcare provisions, there's a couple of key aspects that are worth noting. The version that passed out of the House of Representatives, Speaker Mike Johnson's version of the bill, really focused on capping Medicaid spending. How do we cap and prevent the future growth of Medicaid spending and put some generally common sense reforms into place? Things like more frequent eligibility checks, work requirements, ensuring that there were no non-citizens on the Medicaid program. And then when it came to the dollars and cents, like state supplemental payment programs and provider taxes, they just sought to kind of freeze them and lock them in where they are. When that bill went over to the Senate, it changed drastically. And instead of freezing and capping, they really sought to cut into the dollars that were received by the states. They did so by limiting provider taxes, by phasing them down from currently there's a cap, and we won't get into the minutia of 6% of your net patient revenue for the state. They're phasing that down to 3.5 starting in 2028. And then they sought to have a reduction in state-directed payment programs where they're going to begin phasing those down to where they don't exceed Medicare rates. Basically, there's this debate on whether or not Medicaid should be a better payer than Medicare. And today, because Medicare is such an awful payer, Medicaid is. And instead of saying, well, let's elevate Medicare and spend more to match, they're going to drive Medicaid down to the Medicare rate. And that's going to begin in 2028. And for Mississippi and Louisiana, it's about a $5 trillion cut combined to hospitals. This isn't taking away eligibility. This isn't changing anything within the Medicaid program itself. It's purely a cut to how much money a hospital gets paid for treating a given Medicaid patient. So it's a direct cut to the hospital that's going to be the largest in American history and have devastating impacts on rural health care, if not reversed or mitigated.
Wow. Thank you for breaking that down, first of all. And so the purpose of the bill is to not only reduce the number of people eligible for Medicaid, but also the amount that hospitals get reimbursed for an individual that is covered by Medicaid.
Correct. If you talk to some of the Republicans on Capitol Hill, they would say that the idea is to root out waste, fraud, and abuse. But in their efforts to do so, they're going to drastically cut the amount of money that hospitals are able to get reimbursed for a given Medicaid patient, which will have impacts far beyond that Medicaid patient. It will impact every patient that lives in that community, that seeks emergency care in those communities, especially in rural Louisiana and Mississippi.
So for supporters of the bill and creators of the bill, what was the primary driver for them to drive those cuts down to match Medicare?
Look, where a bill like the One Big Beautiful Bill, it starts as a great idea to extend the Trump tax cuts. And then it meets resistance with some of the fiscal hawks who want to see spending reductions. And so now you've got, obviously, extending tax cuts has a price tag, adding to the tax cuts has a price tag. So we saw spending reductions on the other side of the aisle, and Medicaid is a large bucket of spending for the federal government. And so there was a lot of focus on how can we reduce the federal spend on the Medicaid program. And that's kind of just where we landed. And then you're challenging a member of Congress in order to try and save the Medicaid provisions and not cut Medicaid, they would have to vote against the entire package, which would mean voting against tax cuts, which puts you in a very politically tricky spot as an elected official. Again, the version that passed the House that Speaker Mike Johnson led and helped put together was a much more palatable version of the One Big Beautiful Bill that didn't seek these historic cuts. When it went to the Senate is kind of when it went off the rails. And then when it was coming out of the Senate and the House had to vote to concur, we were up against that July 4th deadline that the president had placed, and the president did not want to back off of that deadline for fear that the whole thing would fall apart.
Yeah.
And so that kind of led them to just vote it through. All of the cuts were delayed, so there are no immediate cuts to the program. They all start after the midterm elections, most of them in 2028. So they figured that there's time to mitigate or reverse those cuts between now and then, and that's something we're already working on.
And do you think that will happen?
I hope it'll happen. If not, you will have a number of rural hospitals across the country, specifically in Louisiana and Mississippi, that will be forced to close because these are hospitals that are already on thin margins. You'll have medical schools that will be forced to close because medical schools are often the safety net provider in their communities that they are. You think about Shreveport, you think about New Orleans, here in Louisiana, and without those public-private partnerships that we have, without them being able to be properly funded, they're not going to have the place for the residents to train. They're not going to have the place for the medical students to rotate, and it's going to put accreditation at risk. The ripple effect of these cuts will be felt in every corner of the state, not to mention that hospitals are major economic drivers in the communities where they're located. They're often the largest employers. And when you start talking about a $4 billion cut, to the state of Louisiana, and those hospitals, there's no way that we're able to protect all of those jobs that we currently have. And so which facilities are going to close, which jobs are going to be lost, it's something that I can't see Congress actually going through in the long term.
So just to reiterate, the cuts that are outlined in the One Big Beautiful Bill for Medicaid do not start until 2028.
Correct.
Okay. And also, the bill primarily affects cuts in Medicaid only, not Medicare. Is that accurate? And if so, why did the bill only address Medicaid and not Medicare?
It's a good question. They only address Medicaid in this bill as they sought to navigate the political dynamics. They wanted to stay away from cutting Medicare. Now, there is some rumor that because of the amount of spending in the bill, that there's something called sequestration that can lead to kind of across the board cuts if you trigger certain levels of spending that could have negative impacts on the Medicare program overall. We'll kind of see how that plays out, but there were no cuts to Medicare in the text. Congress is already talking about, though, another reconciliation package later this year that will target Medicare. And they're already talking about things like site neutral payments and trying to institute some cuts there. And they're certainly going to go after these Medicare Advantage plans and some different aspects of that. But that kind of remains to be seen. Their focus was on Medicaid because of the size of the line item but in the budget that it is, and the relative ease they saw to go after real waste, fraud, and abuse. What happened, though, was you had some programs that weren't wasteful or not fraudulent and are not abusive. They got wrapped up in it all and fell victim to some of the largest cuts.
So you've referred a couple times to the size line item in the budget. Like, what is the line item? What is the size of that line item in the budget?
You're going to ask me that quiz question that I'm not going to be able to answer because I'm not going to get it wrong. It's a big number. I mean, if you go look at the pie for the federal budget, healthcare spending between Medicaid and Medicare is probably just under defense in its size. And it might eclipse defense. I don't think it eclipses defense, but it's going to come close. And it's a significant amount of money, and they, there's a lot of opportunity to find savings within that program. I mean, we all saw the news stories where you would have a Medicaid recipient that was registered and on the rolls in both states, leading to some of those states receiving dollars, or some of those managed care organizations receiving dollars for the same person in two different places. Obviously, we need to find a way to fix that. And in 2025, with AI and with systems the way that they're growing, we should be able to do that. But that's not the same as making sure that a hospital is being paid properly to provide the care for that patient. And that's where we spend a lot of our time educating members of Congress.
Yep. Okay, so the people that are the recipients of Medicaid, those are children, they're people below the poverty line, they are disabled. So tell us, who are the recipients of Medicaid that will be most affected by this as far as their eligibility?
Look, when you're talking about issues like the work requirements, the eligibility checks, and just overall changes to the program, you're going to have folks that are in low income working families that are going to be put at risk if we don't implement these work requirements in the right way to make it easy for folks to show that they are working or trying to work. We certainly don't want someone who is working that full-time job but can't afford commercial insurance to get lost in a paperwork shuffle or not submit the exact right document at the exact right time and then lose their coverage. That's a risk. Again, I'm confident we can overcome those and do this in the right way. I don't think that there's that many people who qualify for these work requirements who are not actively either working or seeking to work today. Obviously, Medicaid provides coverage for pregnant women, for children, for those low-income working families that just can't afford commercial insurance through Medicaid expansion. And those are the people that need this coverage and this access to care the most. You think about those low-income working families that make up to about 138% of the poverty line. In Louisiana, that's only about a $40,000 to $50,000 salary a year for a family with several dependents. And these are families that are working hard. They're either small business owners or they're working blue-collar jobs, but they can't afford their commercial insurance, or they don't have access to commercial insurance through their job. And they rely on Medicaid to have access to preventative care, to access to primary care, to the specialist care, chronic disease management. And if they don't have access to insurance, if we take away their Medicaid, it's not like they can all of a sudden afford to go get commercial insurance.
Right.
Without that Medicaid, a $100 problem today that could be treated in a specialist office or a primary care office is going to become a $10, $20, $30,000 problem tomorrow when they show up in the ER with congestive heart failure that's in an advanced stage, instead of having managed it for months prior by seeing a cardiologist. If they don't have access to the care, they can't afford to access the care, they're going to show up in the emergency room sicker, and it's going to ultimately cost the healthcare providers and the state more money on the backside. And so those are the folks that we're trying to ensure have access to care. But we also can't miss the point that when we cut hospitals to the tune of $4 billion, like the One Big Beautiful Bill does, it's not just Medicaid recipients that are going to suffer. When you lose a rural hospital in the middle of Louisiana in a rural town, that rural hospital provides care for everyone in the community. Let's look at a hospital like one of ours in Our Lady of the Angels in Bogalusa. That is the safety net for Bogalusa. They provide OB services. They deliver babies. And if Our Lady of the Angels were not there, you would have to drive 45 minutes to get to the closest place to deliver a baby. And think about that mom in the middle of the night with an emergent delivery that right now is able to go to Angels, whether they're on Medicaid or not. If that hospital closes its doors, folks are going to lose their life over it. Folks are going to show up sicker when they do get 45 minutes down the road to that ER. It's a scary proposition for not only Medicaid patients, but for all patients that reside in these communities that rely on rural healthcare, and even some of the larger systems that will have to roll back services.
So I've been in healthcare a long time, and I've been reading for years since I've been in healthcare that the Medicare program is not sustainable because of the number of baby boomers that are going to be coming into that program and whatever. So do proponents of these cuts for Medicaid, is it a similar concept that like the program's not sustainable to be funded at the level that it's funded by taxpayer dollars? Is that kind of their argument there?
I mean, the argument ultimately comes back to the overall spending, the federal deficit, the national debt, which we can all agree is skyrocketing. And that's why our system particularly has not been opposed to some of the measures to root out waste, fraud, and abuse in the true sense of the word and find savings where they can be generated. But let's take a step back. Overall, we have to do a better job of keeping people healthier across the country. And that's why we align with the Make America Healthy Again initiative. Nutritional foods, focusing on preventative care. We can't wait until our population is the sickest they've ever been to then provide care, because obviously the outcomes are worse and the care is the most expensive at that point. We have to move the needle on making our state and our nation healthier so that they don't need that expensive emergency care. And that means tackling things like congestive heart failure, diabetes, weight loss, those issues that plague Americans, and we just have to do a better job of addressing them. And that falls not just on the health systems and hospitals, but it falls on each one of us individually.
Totally agreed. So I've read reports that the Big Beautiful Bill will leave as many as 7+ million people without Medicaid. I've also read reports that say 11 million. Like, what is the number? Do we know? Are we just throwing darts at the wall? Like, how many people are going to lose their coverage? And why is the number so high? Is it mainly the work requirements, or?
I struggle with the different numbers. I've seen all of those same estimates that you have. And I feel like it's a bit of throwing darts at the wall until we really see how states begin to implement things like the work requirements. In our conversations with the Louisiana Department of Health, there's a commitment to making sure that those that are eligible, that are doing the things they're supposed to be doing, are not going to get lost in an administrative shuffle and lose coverage over it. And I just struggle to believe that there's that many millions of people who qualify for these work requirements, which means they're not taking care of a child or a sick spouse or parent, that truly are able-bodied without dependents, that are not working or trying to work. And so, I tend to think that those numbers are a bit inflated. We'll see as we move forward. Obviously, our goal is to have as few people roll off as possible that are supposed to be on there. And if they're not supposed to be on there, I think we should all agree and work towards making sure that we get those individuals coverage through alternate means.
So let's talk about the work requirements quickly. So the work requirements are anyone that's able-bodied with no dependents needs to either work, go to school, or volunteer for at least 80 hours in the month. And they have to submit documentation of that. I think it's every 3 months now. So theoretically, couldn't the number of people that will lose coverage be reduced if those individuals just start to meet the work requirements?
Absolutely. And that was my point earlier, was I think there's a lot of them that are already doing it and that are somehow just being thrown in that number as if they're not. And then I think the ones that aren't, once they realize that they need to, they will. And
so there's no work requirements they have to meet today at all?
I don't believe, some states may have different aspects, like Georgia's done it, but there's not typically a work requirement where you have to be seeking this in order to qualify for the coverage. But look, ultimately, we believe, and it's good public policy to believe that we want all of these Medicaid recipients to move off of Medicaid and onto commercial insurance. Because when they're able to move off of Medicaid, not only is it going to save the federal government and the states money, but that means that person now is moving to a place in life where they have a job, where they can afford or are offered that commercial insurance. And that's good for everybody. It's good for the economy. It's good for ending generational poverty. And so that has to be a whole of government approach that includes education, that includes economic development, that also includes the health system to ensure that we can move people from dependence to independence.
And so I know you said the cuts don't take effect till 2028. So at what point do hospitals begin to feel this impact and this loss in reimbursement? And what are hospitals going to do to offset that lack of reimbursement?
That's a really good question. And typically, everything in Congress comes down to the wire, right? And so my hope is that between now and midterms, we can begin to seek and see progress toward a fix for these cuts that are not slated to take effect until 2028. Once 2028 gets here, we're looking at a phased-in approach where it's going to be 10% a year. So it'll probably take 7 to 10 years for the full magnitude of that $4 billion annual cut to be felt in a state like Louisiana. But once you get to 2028 and July 1 comes and that first 10% reduction hits and Congress has refused to fix it, sure, it might only be a couple $100 million spread across the state, but the ripple effect that's going to have in that it's going to pause investments. Any board or hospital executive isn't going to say, well, let's go build that new building or let's go invest in expanding access if we know they didn't fix it, and every year for the next 7 to 10 years is going to be a 10% reduction year after year after year with no growth. You're going to pause those investments and you're going to retreat to the boardroom to say, how do we get ready for year 2, 3, and 4 of these cuts? Who are we going to lay off first? Which service line are we going to reduce first? Which hospital are we going to close first? Those are going to be very real conversations that are going to begin to occur, as you might not have to close the doors on day 1 or even year 1, but you know that if they're unwilling to stop it in year 1 and you get to year 5, that you're going to start feeling the financial pressure of those cuts that are building and building and building. But again, our hope is between now and midterms we can see a fix, because I don't think that it was the president's ultimate intent to cut the program the way the Senate did. I just think it fell victim to the process. And our hope is that between the House and the president, we can come back and they can do the right thing.
So do the politicians that you're speaking with in Washington understand that impact that you just laid out there? Because I would think, those individuals would have empathy and there would be bipartisan support for trying to keep hospitals open and access to care available.
You would think, and it's a point of education that we focus on year round. in focusing not only on the Medicaid population, but also focusing on the impact on everyone else in the health system, the commercially insured, those on Medicare, and even beyond the patients. The fact that hospitals are such major economic drivers in their community, they're the largest employer. They contribute billions of dollars to the economy in their state every single year, tens of thousands of jobs to their state. And to put those at risk for a budget line item and to say you generated some savings, it just doesn't make sense, because ultimately the impacts are going to be far reaching. And ultimately they'll be felt, I believe, at the ballot box.
What do you say to those that have said the one big beautiful bill is basically just repealing Obamacare?
There were some provisions that were debated early on that were a more direct affront to the Affordable Care Act, seeking to ratchet down the federal match for Medicaid expansion states, being one of them right now. Those Medicaid expansion states have a 90-10 match. And they saw there were some early discussions about maybe ratcheting that down, which obviously would force, through some trigger laws, some states to repeal Medicaid expansion. There was also some talk about doing things like block grants or per capita caps, all of which could have a negative effect on just the general Medicaid program and the enrollment, and forcing the states to pay more. We were able to walk a lot of that back. As bad as the bill was in terms of Medicaid, where it ended, it could have been so much worse. So I would not say that the bill as it stands today is necessarily a repeal of the Affordable Care Act. It does try and chip away at the edges at some pieces of it. But again, the Medicaid program, I try not to talk about it with ACA and non-ACA. The Medicaid program is the Medicaid program as it is today. We passed the Affordable Care Act more than 15 years ago now, and it's the law of the land. The federal matches are what we agreed to when states sought to expand Medicaid for these populations. The federal government's going to have a really tough time going back on that promise. And if you're asking states to pay more so that the federal government pays less, all you're asking governors to do is raise taxes on their hardworking families. And obviously, as the purpose of the one big beautiful bill was to give a historic tax cut to working families, I don't think that's what President Trump wants to do.
So if there were any changes to the one big beautiful bill, and it sounds like you will continue to lobby over the next couple of years for changes, like what would you like those changes to be?
Look, first and most important is we have to reverse the cuts to state-directed payment programs. And these are those dollar cuts directly to the hospitals and what they're paid and reimbursed for providing care to Medicaid patients. That's the $4 billion in Louisiana, the $1 billion in Mississippi. Over the course, that'll be phased in and be an annual cut. We've got to reverse that. We've got to go back to some ceiling that is above Medicare, but below 100% of average commercial rate, which is where it is today, and land on something that is reasonable. And we can do that. We can find a solution that is not just taking a hatchet to what hospitals are reimbursed. Number two, provider taxes. This ratcheting down of provider taxes, where basically states are able to tax hospitals to generate the non-federal share of the Medicaid program. Instead of asking my family or your family to pay taxes to support the Medicaid program, hospitals are asked to pay that non-federal share. And it forces the hospitals to put skin in the game and to have a say in putting that skin in the game to generate the match for the federal government. And that's a good thing. Governor Landry sent a letter to President Trump earlier this year saying that provider taxes are conservative and that he strongly supports them. And we agree with them. So ratcheting that down to 3.5% of your net patient revenue is just an unnecessary cut. The 6% was a ceiling that had already been put in place by Congress many years ago. And we think that they had it right then, and they should go backwards on that. But again, all of this is a little bit of a give and take. They're already talking about the next round of cuts they want to do. And so we're going to have to, for Medicaid and Medicare, between now and midterms, we're going to have that dialogue with House and Senate leadership, with the White House, And as midterms come closer, the fate of their parties at the ballot box will obviously play an increasing role as well.
Any hopes for how states approach Medicaid moving forward?
Look, states have to be innovative. They have to be innovative in how they deliver care, how they hold the managed care organizations accountable to things that are outside of hospitals' control. You can't look at hospitals and health systems as the end-all be-all to fix the health of a state. It begins with nutrition. It begins with access to food, things like food deserts. It includes the social determinants of health, like is there transportation to doctor's appointments? The ability to find good paying jobs. All of these aspects go together to impact the health of a population, and states have to get innovative in how they're working with their managed care providers, with their health systems, with their SNAP programs, to ensure that they're all seeking to achieve the same goal, which is have a healthy and vibrant population.
Brian, thank you so much. Any parting thoughts you want to leave us with here?
Of course, thanks so much for having me on. These are tough topics. They're weighty topics. And we often say that there's two things you don't want to have to watch be made, and that's sausage and legislation. It's a messy process. But it's my privilege and my team's privilege to work on behalf of FMOL and all of the patients that we serve across Louisiana and Mississippi to sift through these complex negotiations and protect the funding that allows us to deliver our mission to the people that we're privileged to serve. And we're going to keep doing it.
Well, thank you for your hard work. And anyone not from Louisiana is not going to understand your sausage reference, but the Louisianians do. So
there you go. Google it.
Thank you, Ryan, for your time.
Thanks for having me.
You have been listening to the Louisiana HIMSS podcast, where we have engaging conversations with Louisiana healthcare leaders. This podcast is a production of the Louisiana chapter of HIMSS, the Healthcare Information Management Systems Society. If you would like to learn more about us, please visit us at louisiana.himss.org. That website again is louisiana.himss.org. You can also find us on LinkedIn by searching Louisiana HIMSS, or just email us directly at louisianahimss@gmail.com. If you found this podcast engaging, please like and share it. And don't forget to subscribe so you don't miss our upcoming podcasts. Thank you so much for joining us, and we'll see you next time.